Arterial aging starts earlier than most people think. Most people associate arterial disease with old age. Biologically, arterial stiffening often begins in your 30s, and it can begin even when you feel completely healthy. Arteries are not rigid pipes. They are dynamic, elastic structures designed to expand and recoil with every heartbeat. This elasticity allows blood to move efficiently and reduces strain on the heart. When arteries are flexible, systolic pressure is absorbed smoothly. Blood flow remains stable. Organs receive consistent oxygen delivery. In your 30s, subtle changes begin to occur inside the arterial wall. Elastin fibers, which provide stretch and recoil, slowly degrade. Collagen content gradually increases. Collagen is stronger but less elastic. This shifts the structural balance of the vessel wall. At the same time, endothelial function may begin to decline. The endothelium produces nitric oxide, which helps blood vessels relax. When nitric oxide production decreases, arteries lose part of their ability to dilate. These changes do not cause pain. They do not immediately change how you feel during daily activity. But they increase arterial stiffness at a microscopic level. Hormonal shifts also play a role. Growth hormone levels gradually decrease after early adulthood. Testosterone and estrogen begin slow declines. These hormones influence vascular repair, collagen turnover, and nitric oxide signaling. Insulin sensitivity may also start to decrease in the 30s, especially with sedentary behavior. Elevated insulin promotes low-grade inflammation. Chronic inflammation accelerates structural remodeling of arterial walls. This is how arterial aging begins, not with blockage, not with symptoms, but with subtle structural and hormonal shifts that slowly reduce elasticity. The structural shift inside the arterial wall. To understand arterial stiffening, you need to understand arterial structure. The arterial wall contains three main layers. The innermost layer is the endothelium. Beneath it lies smooth muscle tissue. Surrounding this is a matrix made primarily of elastin and collagen. Elastin allows arteries to stretch with each heartbeat and recoil during relaxation. This recoil maintains forward blood flow and reduces cardiac workload. Collagen provides strength and structural integrity. However, collagen is significantly less elastic than elastin. Beginning in your 30s, elastin fibers gradually fragment. Mechanical stress from constant pulsatile pressure contributes to this breakdown. Elevated blood pressure accelerates it further. Unlike many other proteins in the body, elastin has very limited regenerative capacity. Once it degrades, it is not easily replaced. As elastin declines, collagen content proportionally increases. The artery becomes thicker and less compliant. This process is known as arterial remodeling. There is also a biochemical component. Chronic exposure to elevated glucose leads to the formation of advanced glycation end products. These compounds bind to collagen fibers and make them stiffer. This further reduces arterial flexibility. Oxidative stress plays an additional role. Reactive oxygen species damage endothelial cells and disrupt nitric oxide signaling. Reduced nitric oxide impairs vasodilation, making arteries functionally stiffer even before structural changes are severe. Smooth muscle cells within the arterial wall can also shift phenotype under inflammatory conditions. Instead of remaining contractile, they become more synthetic and produce extracellular matrix components that increase wall thickness. These structural and biochemical shifts happen gradually. You do not feel elastin degrading. You do not feel collagen stiffening, but pulse wave velocity increases. Systolic pressure rises slightly. The heart must generate greater force to eject blood. This is how arterial stiffness progresses quietly. The hormonal and metabolic drivers behind early stiffening. Arterial stiffening is not only structural, it is strongly influenced by hormones and metabolism. One of the earliest contributors is declining insulin sensitivity. When cells become less responsive to insulin, circulating insulin levels rise. Chronically elevated insulin increases sympathetic nervous system activity. Increased fluid retention raises blood pressure. Even mild elevations in pressure increase mechanical stress on arterial walls. Cortisol plays a similar role. Persistent psychological stress keeps cortisol elevated. Cortisol increases blood pressure, and enhances inflammatory signaling. Chronic exposure accelerates collagen deposition within arterial tissue and impairs endothelial repair. Growth hormone gradually declines after early adulthood. Growth hormone supports tissue regeneration and endothelial function. As its levels decrease, repair of microdamage within the arterial wall becomes less efficient. Sex hormones also influence vascular health. Estrogen enhances nitric oxide production and protects against collagen accumulation. As estrogen declines in women, arterial stiffness can accelerate. Testosterone influences vascular tone and smooth muscle behavior in men. Gradual reduction may alter endothelial responsiveness over time. There is also a mitochondrial component. Reduced physical activity lowers mitochondrial density in skeletal muscle and vascular cells. Lower mitochondrial efficiency increases oxidative stress. Reactive oxygen species damage elastin and disrupt nitric oxide availability. This combination creates a reinforcing cycle. Metabolic stress increases inflammation. Inflammation promotes structural remodeling. Structural remodeling increases stiffness. Increased stiffness raises blood pressure. Higher blood pressure further accelerates elastin degradation. All of this can occur while cholesterol values remain within normal range and daily energy levels feel stable. How arterial stiffness strains the heart when arteries lose elasticity. The impact is immediate at the level of hemodynamics. Healthy arteries expand when the heart ejects blood. This expansion absorbs part of the pressure wave. During relaxation, the artery recoils and helps maintain forward blood flow. This buffering effect reduces strain on the heart. When arteries stiffen, this buffering capacity declines. The heart must generate higher systolic pressure to move blood forward. Pulse pressure widens. The reflected pressure wave from peripheral vessels returns to the heart earlier than it should. This early wave reflection increases left ventricular workload. Over time, the left ventricle adapts by thickening. This process is known as left ventricular hypertrophy. Initially, it helps maintain cardiac output. Long-term, it reduces efficiency and increases oxygen demand. Stiffer arteries also impair coronary perfusion. Coronary blood flow primarily occurs during diastole, when the heart relaxes. If arterial stiffness shortens diastolic time or raises end diastolic pressure, oxygen delivery to cardiac tissue becomes less efficient. This increases vulnerability to ischemia even before significant plaque buildup develops. Another consequence is microvascular stress. Smaller blood vessels in organs such as the brain and kidneys are exposed to higher pulsatile pressure when large arteries lose compliance. Over years, this contributes to microvascular damage and increases risk of cognitive decline and kidney dysfunction. Importantly, these changes develop gradually. You may feel normal during daily activities. You may have no chest pain. Routine tests may appear acceptable, but the mechanical load on your cardiovascular system is increasing. How to slow and partially reverse arterial stiffening. Arterial stiffening is progressive, but it is not entirely irreversible. The goal is not to restore arteries to teenage elasticity. The goal is to slow structural remodeling and improve functional flexibility. The first priority is improving endothelial function. Regular aerobic training increases shear stress along vessel walls. This directly stimulates nitric oxide production. Higher nitric oxide availability improves vasodilation and reduces functional stiffness. Even moderate intensity walking performed consistently can improve vascular responsiveness. Resistance training also plays a role. Properly structured strength training improves insulin sensitivity and reduces baseline sympathetic tone. Improved metabolic control lowers inflammatory signaling inside the arterial wall. The second priority is metabolic stability. Improving insulin sensitivity reduces advanced glycation end product formation. Lower glucose variability decreases collagen cross-linking and oxidative stress. Maintaining healthy body composition reduces chronic inflammatory burden. Sleep quality is equally important. Deep sleep supports growth hormone release. Growth hormone assists tissue repair and endothelial recovery. Chronic sleep restriction increases cortisol and accelerates vascular remodeling. Blood pressure control is critical. Even mildly elevated systolic pressure increases mechanical strain on elastin fibers. Lifestyle interventions that reduce resting blood pressure reduce daily structural stress on arteries. Finally, consistent physical conditioning improves mitochondrial efficiency. Lower oxidative stress protects elastin and preserves nitric oxide signaling capacity. The key insight is this: arterial stiffening begins quietly in your 30s because structural, hormonal, and metabolic shifts accumulate gradually. You may feel fine, but vascular elasticity reflects biological aging more accurately than how you feel on a given day. Protect endothelial function. Maintain insulin sensitivity. Train your cardiovascular system. Control blood pressure early. Arterial health is not about reacting to symptoms. It is about preserving elasticity before stiffness becomes structural.